Welcome to the Invisible Diagnosis, the 5-minute show where one diagnosis meets another, and we ask, what gets lost in between? I'm Elle. Today, what happens when borderline personality disorder hides behind an IQ score? And joining me is Gabriel, a clinician who works in dual diagnosis. Gabriel, welcome.
Thanks, Elle. Glad to be here.
Okay, let's set the scene. So, why is borderline personality disorder in someone with intellectual or developmental disability such an quote invisible diagnosis?
Well, that's a great question, Elle. Biologically and neurologically, BPD looks a lot like IDD's quieter cousin. People with BPD show a hyperreactive limbic system and impaired executive neurocognition, things like inhibitory control, memory, and processing speed. That's from an article by Furtek and colleagues in 2006. Now, those same circuits are already vulnerable in IDD because of developmental brain abnormality for Wink and colleagues 2010. So, you have two conditions standing on the exact same wire.
Mm-hmm. And psychologically, Gabriel?
Well, Linden's biosocial theory says BPD blooms when a biologically vulnerable child meets an invalidating environment. That's Linden 19. Children with IDD are exquisitely vulnerable to that combination. They're at significantly higher risk of sexual abuse, per Turk and Brown 1993, and their parents often grieve the disability itself, which can disrupt secure attachment, as seen in Holland's Instance in 2000.
So psychiatrically, you're looking at a textbook for borderline personality disorder setup wearing an intellectual developmental disability costume?
Yeah, exactly. Affective liabilities, self injurious behavior, fear of abandonment, impulsivity, all of it. Cluster B disorders affect about 4.5% of the general population, seen by Huang and colleagues 2009, and BPD specifically about 5.9%, as seen in Grant and colleagues 2008. There's no biological reason that number should disappear at an IQ of 65.
Then why does the diagnosis vanish in this population?
One word, overshadowing. Diagnostic overshadowing is when clinicians attribute every symptom to the IDD itself. The self harm becomes, quote, just behavior. The rage becomes, quote, just frustration, as seen by Gentle and colleagues 2022 and Khan 2026. In another article, Wink and colleagues documented 3 patients hospitalized over 100 times for self injury before anybody even considered BPD.
Ooh, 100 times. That's a barrier with a body count. And Gabriel, what's the fixed?
Fix could be training every clinician on the DM-ID-2. That's the adapted diagnostic manual for this population, which explicitly states people with IDD are not exempt from personality disorders, as seen in Fletcher and colleagues 2018. That single line on a single page would change practice overnight.
Oh, any second barrier that you can think of?
As for second barrier, I'd say the assessment crisis. The MMPI and most personality inventories were never normed on people with cognitive deficits, so they produce unreliable data. Gentle and colleagues, 2022. The fix is prioritizing collateral data from caregivers and family who know the person's baseline and anchor the diagnosis to the DM-ID-2 criteria.
And how about the third?
The third one, I would say staff turnover and fragmented teams. There's inconsistent direct support staff, which means there's no therapeutic environment, just daily improvisation. The fix is the one ABA can champion,
Hmm.
investing in staff cohesiveness. Train every direct support worker on the diagnosis and use identical limit setting language across the team.
So, if we know what borderline personality disorder looks like in an intellectual developmental disability and why it gets missed, what do we actually do about it? So Gabriel will walk us through assessment first.
All right, these are excellent questions. So, best practice is a multi model workup anchored in the DM ID 2. That's Fletcher and colleagues 2018, and our gold standard adaptive criteria. Layer that with a structured clinical interview, longitudinal behavioral data, and a functional behavioral assessment, and collateral history from caregivers and the family. The FBA is non-negotiable. It lets us separate operant self-injury that's maintained by attention from the effective dysregulation that signals BPD. Same behavior, very different function, very different treatment plan.
And once we have an accurate diagnosis, what does the intervention plan look like, Dr. Morales?
Great question again. So, two evidence based pillars. There's pillar one, which is adapted dialectal behavior therapy, Leinen's four module DBT, mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness, modified for IDD with concrete visuals, shorter sessions, simpler language, and caregiver coaching built in. Pillar two is ABA scaffolding built on the three-term contingency: antecedent, behavior, consequence.
Dr. Morales, could you please give me some concrete example for it?
An example? Absolutely. So the Wing Case series, they built a structured level system with visual feedback, posted chore and goal boards, and uniform staff limit setting languages. The result was weeks at a time without self injury, and the team was able to taper antipsychotic medication, as seen in Winking Colleagues 2010.
So, DBT plus ABA therapy and architecture.
Exactly. DBT teaches the skill while ABA builds the environment and lets that skill stick. You can't talk someone into emotion regulation in a chaotic environment.
So, Dr. Morales, could you give me the takeaway then in one breath before we wrap this up?
Yeah, for sure. People with IDD aren't immune to borderline personality disorder. They're underdiagnosed. Look past the overshadow, use the DM-ID-2, pair DBT with ABA, and change the trajectory of a life.
All right, so the invisible diagnosis, making the invisible evidence based. Thanks for our clinician, Dr. Gabriel Morales, and thanks for watching.
Thank you for having me, Miss Salazar.
Okay, goodbye.
Bye.